warm welcome to In the Loop, the podcast where we focus on developments in our health and care system. I'm Neil Dixon, former broadcaster and health leader, and with me, as ever, is Roy Lilly, relentless commentator and also a former health leader. Hi, Roy.
Hello, Neil.
Our guest this time is Dr. Penny Dash. Penny has spent the last 20 years working for McKinsey, analysing the NHS and other organisations, and often finding them wanting. Now, for a while anyway, she's been given one of the key roles that will guide the health service over the next couple of years, Chair of NHS England. It's an unusual job because, of course, the government, as it appointed Penny, almost simultaneously announced it intended to abolish NHS England and merge its functions back into the Department of Health and Social Care. Penny has also just produced for the government a review of patient safety and quality, which concluded, among other things, that the focus on safety in recent years has been at the expense of other aspects of quality, which has resulted in clinical staff spending their time checking on other clinicians. And she says the vast majority of these recommendations are not costed, and we don't know their expected impact. Meanwhile, the Health Secretary, Wes Streeting, has produced a 10-year plan, promising to reimagine the NHS through transformational change that, quote, will guarantee its sustainability for generations. It repeats the mantra about shifts from hospital to community, from analogue to digital, and sickness to prevention. And no one can fault the ambition, but there has been a lot of concern about the detail. Plans are great, but the devil is in the implementation. How credible is the ambition? What will the impact be of yet another massive reorganisation? Will there be funding to transform services which have been underfunded for years, especially when it comes to capital? What about social care? And will there be any challenge to the vested interest of staff groups? Roy, I think we want to concentrate on three areas, don't we? First, the abolition of NHS England, sensible rationalisation or self-inflicted wound. Second, Penny's report on safety and quality, a pretty damning indictment, but is her recipe to address this the right one? And third, does this super ambitious 10-year plan add up financially, organisationally, or in terms of making the service more productive and efficient? Your take, Roy?
I mean, the irony of this is that this woman has spent 20 years with McKinsey, one of the biggest consultancies in the world. If you ask McKinsey, how will we go about abolishing NHS England, they would say, right, well, do a plan, do implementation, do an impact analysis, do a costing, figure out how you're going to do it step by step and go about it cautiously. But over a weekend, Wes Streeting decided the game's up and we'll get rid of them. It's total chaos at NHS England. I know it is from the people who I talk to there. People are terrified they're going to lose their job. All this has got to be done by Christmas. Well, the NHS England hasn't, but the impact of it all with ICBs and other places, they've got to get rid of half of their people by Christmas. What kind of working environment is that? And would McKinsey ever have endorsed it? I don't think so. And then we've got the 10-year plan with no implementation, no impact analysis, no costing, no funding, and half the staff won't be here to do it.
So, first of all, on the NHS plan itself, do you accept that the ambitions are all right? Because it seems to me the ambitions are fine, and indeed some of the proposals make some kind of sense. My problem with it is I don't think there's any oil to lubricate the engine. And they're not talking about making fantastic efficiencies within the system, which will release money. And the demand that is likely to exist over the next few years is going to make it extraordinarily difficult just to go on providing services, never mind make them a whole lot better.
Well, you've said it all, haven't you? It's a 10-year plan. So we're entitled to ask, in a 10-year plan, what will happen 3 years from now? What will happen 5 years from now? And what will happen 7 years from now? The answer that she can give is, I don't know. Somebody somewhere will be doing something. I'm not sure who, because we don't know how many staff we're going to have left. And also, it's worth looking at the money, because the money between now and 2029, which is 4 years into the plan, is 2.8% uplift a year with a huge amount of growth. We know there's going to be growth. We know the demand is going to go up. We know the costs are going to go up. You know, inflation is going to put them up. I mean, we'll have just about enough money to buy the bog rolls.
When the health service does make advances, Usually it's because they're getting more money during those years. And secondly, when there is genuine technical innovation. I'm just not clear how quickly or how effectively they will embrace this next technical revolution. I suspect it's pretty great. It's going to be very great, but it will also change the way staff do things. And therefore, I think there also will be a challenge to unions and staff interest groups who may find it difficult.
Absolutely. Since the man invented the printing press, the trade unions got their pram, didn't they? So, I mean, that's just part of the history of the world. But I agree with you. And I just don't see the how in this. Really, this is just implementation, isn't it? You're saying to me, do I think the stuff in the plan is good? Well, of course I do. It's the sum total of God knows how many focus groups, and everybody who's got an idea about what they want for their department or their specialty or something, you just chuck it all in and say it's a 10-year plan. Remember Sir John Harvey Jones, the guy that used to do the consultancy guru thing for business on the BBC? He said no organisation could do more than 3 things at once. This plan has got 26 new initiatives in it and about 19 other bits. I have to look it up. But it is a complete nonsense without a plan.
Well, on that unbiased note, let's go and welcome Penny. Penny, thanks very much for joining our podcast. And let me begin. It must have been a bit of a shock, having just been appointed as chair, to learn you were then going to be abolished.
Indeed. And in fact, I got some rather amusing WhatsApp messages, as you might imagine, of which the best one was my daughter saying, "I think the Prime Minister's just fired your mum," which went down very well in the family. A few things. One is I did actually know in advance. I knew that there was a long-term plan, certainly, to bring together NHS England and DHSC. In terms of the exact date, I knew about a week in advance when it was going to be announced. So this may sound slightly strange, but I'm not sure it really changes that much for me personally. I felt there's a job that needs to be done. The reality is it will take time to get this through legislation, which indeed it will, and therefore my job continues, albeit I'm working more closely with the Department of Health and Social Care, which I would have expected to do anyway. I think the bigger question for me on a very personal level is, well, what does the future board of the Department of Health and Social Care look like? There's an interesting bit in the 10-year plan about that future board taking on some of the functions that the previous monitor used to do around regulating foundation trusts and the new integrated health organisations, as well as potentially the wider system. So I'm sure there will still be plenty to do. I think the question for me personally is, how long do I want to keep going for? And when I came into the job, I took on an up to 4-year contract, and that's still my timeframe.
So are you broadly in favour of the idea, I assume you are, of merging the two? NHS England had started off as a relatively modest NHS commissioning board before becoming a bit grander and then swallowing all these other organisations, NHS Digital, NHS Improvement, Health Education England, to name but 3. So you could get lost in the alphabet soup of organisations.
You could indeed. I mean, as ever, there are pros and cons. And I actually worked in the Department of Health and Social Care 25 years ago when it was a single organisation, then been very involved in the health system, seeing it separate out, seeing it go through all of those different phases, as you say, Neil. I think there's some very strong rationale for having NHS England or the NHS as a commissioning board, as you say, having that to be a separate arm's length body. Equally, having been working here essentially since about the middle of March, it is extremely complicated in its current setup. And I'd go as far to say I don't think it could have continued working in that way. So to have the level of duplication of teams and this back and forth, I mean, it's still like that now, despite all of the best intentions of very high caliber people working here in NHS England, working in the Department of Health and Social Care, the level of complexity that we have to go through, the lack of clear governance structures, the lack of clarity about who's making what decision, where. I've just been having a conversation about the future of neighbourhood healthcare. Where does that get decided in this dual organisation is not straightforward. And so at the moment, I feel, as I think do, well, certainly most of the people I feel I'm coming into contact with in NHS England Department of Health, that actually it will be more straightforward in the combined entity. But of course, we'll then be back to the challenges that we had when it was a combined entity and all the things that people would say about too much political involvement and how much can you really do within a Department of State.
It's just gone round in a horrible circle, hasn't it, really? I mean, I remember the Lansley reforms very well. People at the time said it was like a Jackson Pollock picture. And I hated the Lansley reforms, but I really liked the Lansley reforms because of NHS England. The rest of it I slated, but the whole idea of this arm's length body, I thought was a blooming good idea. Then, of course, along comes everybody says, oh, it's tremendous duplication. The duplication was never in NHS England. The duplication was because the politicians in the department wouldn't let go. It's been messed up by the Department of Health. But what I feel really sorry for are the people who committed their lives and careers to NHS England, who now don't know whether they're going to get a job. You can't tell them what kind of redundancy payment they're going to get. Why the hell would any of them work there? If you look at the Porter studies of mergers, 18% of top people bail out, and you're already losing top people. It looks to me so un-McKinsey, might I put it like that. And I feel sorry for everybody working there. And if you're listening to this and you work there, I think you should create hell.
So it's not good. There's an awful lot of people who are being put through a considerable change programme. And that never is a great place to be. But I come back to, it was pretty hard to stay as it was, and to a degree as it still is. Every day, we're literally trying to have a better system in place to address that duplication.
Is there a plan or an impact analysis or a timeline?
Well, there is a team, and then there is a programme board, which myself and Alan Milburn co-chair, and Sam and Jim are the two chief execs. Of course, none of this was helped by not having permanent secretary for the first 3 months post the announcement. That's had a really big impact. So Sam has formally been in post since the middle of June.
Just for clarity, we're talking about Sam Jones, former nurse, NHS chief executive, been around the block, knows the score.
Yeah.
How do you avoid the previous efforts whereby people were made redundant and then re-employed again in a sort of slightly different role, but at higher salaries? Is that going to happen?
Yeah, we do still have in NHS England a governance structure, remember, until we are abolished. So we have a people and REMCOM, and we're asking to see all of that, and we're reviewing it, and we're going through. And it's not just, of course, for NHS England, it's also true for the ICBs as well. Which I hadn't fully realised the redundancy deals are actually quite different now than they were in the past as well.
Are you talking about Mars, or are you talking about redundancy?
Redundancy, but I'm not an HR expert, so don't ask me about the details. But we are certainly asking the question that Neil just asked.
And ICB's not really a great success story up to now. And now we're going to rely on them to make everything right with fewer people and fewer resources.
I think it depends when you say not a great success story. I would say in my previous role in North West London, we achieved quite a lot. Nothing like as much as I would like to have done, but we did achieve quite a lot. The big thing is, exactly as you say, Neil, we are going to have to put a lot of focus on getting the ICBs to be effective commissioners of services. You know, what we did in the PCTs, I was quite involved in the World Class Commissioning Programme. I mean, that was a massive programme of support, of developing different tools, different approaches, expertise, case studies, you name it. It was not small fry, right, to get the PCTs to a place where they understood basic principles of market management, of commissioning, of understanding costs, understanding price, recognising the two are different, projecting demand.
Please tell me we're not going to go back down this market thing again.
We did have delivering the NHS Plan 2004-5, which introduced plurality of provision.
I mean, there was never any evidence that the commissioning thing improved quality or got a handle on cost. In fact, I mean, this whole choice thing, I think, is, I don't choose my words carefully, but I think it's overrated. People just want to have local convenience services that are safe and trustworthy. They don't want to go shopping for their healthcare.
I actually disagree. I think there is a possible role. But my question, added on to Roy's challenge, I guess, is how do you get competition and choice to work in a market with such overstretched resources? It's not as if you've got excess capacity, which people can move from one thing to another. You've got a place where everybody is overstretched, and also putting across something that ends up penalising those who are struggling. That doesn't seem to make much sense either.
So I think we need to look at different services and look at the data for different services. Different things work in different ways. And of course, if we are to have choice and we are to have a market, then we have to operate that in the most effective way. And that's the bit I will keep coming back to. So the former, to a degree, is a political choice. The latter is down to me, us, the exec team. So one of the things I've been pushing for quite heavily, and Jim Mackey and Elizabeth O'Mahony's finance director are very much working on, is how do we get a much better tariff structure? Now, that's not just tariffs to underpin choice, that's tariffs to underpin everything that we do. We may not necessarily have it for absolutely everything, but we should certainly have much more robust tariffs for our core activity. And by robust, I mean tariffs that reflect cost. Don't reflect average cost across the country, but reflect what things should cost if we were working efficiently, effectively, and to high quality. And many of the things which are currently operated under a choice mechanism and under a tariff structure are actually some of the more straightforward things to quantify. But at the moment, often our tariff structure, as I say, is based on that average cost and also doesn't necessarily fully reflect case mix or additional levels of complexity, like doing training at the same time as operating, for example. With particularly now, different to 20 years ago, we've got way better data, we've got much better analytical tools. There's no reason why we can't have a much more sophisticated tariff structure, as indeed other countries have. And that is something that I think we've absolutely got to get on top of. And we're already starting to develop new tariff structures with some of the most common procedures, so that we ought to be able to say, this is actually a reasonable price to be paying for this particular procedure. And we could do it on a cost plus mechanism or whatever, but it's got to be a should cost, not a does cost. And that means saying, if you're working efficiently, effectively, and to high quality, this is what something should cost.
How are you going to collect the data on that? At the heart of all this is coding.
No, coding is once you've done it. This is saying up front. So, for example, GIRFT, quite a big fan of GIRFT. So you can go from the GIRFT work, which would say, for example, for this sort of hip replacement or this sort of cataract or whatever, with this level of complexity, this is how long it should take. It can also say this is who could and should be doing the procedure, this is the rest of the team. Now, we can also go and look at, well, is this a reasonable size of team to have in operating theatres? So Stella Vig, who's the National Clinical Director for Elective Care, she's done some interesting work that looks at numbers of staff in operating theatres in different countries. And people might be surprised to hear that we have more staff in our operating theatres than any other country in the world.
Is that a good thing or a bad thing?
I think if one looks at it, is that allowing us to do as many procedures as we could, which would maximise health? It is not a good thing, not a good use of resources. And so that would be an example of saying, if we took the GIRFT approach, which has also looked at workforce models, and we said, under GIRFT data, this is what it should cost. And of course, then looking at good procurement as well for things like prostheses. So you can get to what should be an appropriate tariff. And that's the sort of work that we're trying to do to underpin choice mechanisms.
How does the tariff underpin choice?
Well, because if you have a tariff that is in particular very high, and you have full open choice, which is what we have at the moment, so an independent sector provider only needs to get one contract with one ICB in the country, and then anybody can go to them. And if you look at what's happening on things like ADHD, autism assessments, where we've got a very, very high tariff, which I would say is considerably more by quite some margin than what things should cost, and we have open choice, then you start to get a market that is not working.
Okay, let's move on to your safety and quality report. Your report is a pretty damning indictment of the NHS's attempts to improve safety. We seem to be worse, I think, than other comparable healthcare systems. Or are we just better at exposing our errors?
We're not actually that significantly worse. I did in the data, I set us a pretty high bar in the analysis I used. I said if we were to be at the top quartile of other OECD countries, and of course, that's a pretty high bar to set ourselves. And actually, when you dig down into the OECD data, we're certainly not worse than the average. So it's worthwhile looking at some of that data in quite a lot of detail. So that's number one. Secondly, we definitely measure things a lot more than most other countries. Not all. Sweden is very good for measuring clinical quality, but we do measure things a lot more. So one could argue, but we don't have sufficiently good data to do that. Maybe we expose more things here. The point I was making was that what we have done is set up an awful lot of inquiries and new regulators over the last 10 to 15 years. And one could argue that that has been, to a degree, at the expense of actually sorting out some of our systems ourselves in terms of how we run things. And what I would point to is that the work that has taken place more within the system, so things like the patient safety investigation function, is now starting to grow quite considerably. That now means that within NHS providers, if something goes wrong or if you think that something has gone wrong, there is now a whole mechanism in place that can start to address that very quickly. You don't have to wait to go to the CQC or wait to go and call for a national inquiry. There's now a whole team of things internally within the NHS that can start to investigate things. So my observation was we've created an awful lot of mechanisms, systems around the NHS, which to a degree have ignored what are we actually doing within the system and how do we get boards to look at, in particular, safety, but also effectiveness and, crucially, patient experience much more systematically, rather than essentially outsourcing those to all these other organisations, which you would not see in other healthcare systems or in other industries.
Is there not a danger, though, that you leave trusts and so on to sort this out themselves,
yes,
and that they don't have the external objectivity, or indeed, as does and has happened, people actually end up covering things up all the time, and it's the external eyes that expose it.
Yeah, so I'm very, very conscious of that. So a couple of things. One is we haven't got rid of CQC. I published this report last summer about CQC and all its challenges. We need a significant improvement programme within CQC itself. So we absolutely got to keep CQC. When I was doing that review of CQC, and indeed this review, a number of people did ask me to get rid of CQC and get rid of all regulation. No, we have CQC and we absolutely keep CQC. But CQC is our quality regulator, and we need to give CQC the tools, the capabilities, and indeed the resources to be able to do its job properly. So that's one bit. But the second bit is that, absolutely, Neil, and it comes back to the ICBs and the commissioners. We need much stronger ICBs that themselves could be looking at quality of care in a much more robust way. I was quite surprised when I was chairing an ICB at the quality data that we were looking at, or rather weren't looking at. We spent a lot of time looking at a few specific metrics which are not significant drivers of morbidity and mortality. And we weren't looking at the things that really make a difference to morbidity and mortality. And that's something which needs to start to change. So we need commissioners and provider boards to be much more on the front foot of that. You'll have all heard Jim talking a lot about putting financial accountability back into providers. I'm talking about putting quality accountability back into providers, and we're both banging the drum on both of those.
The other issue is about safety. We had a really interesting discussion with Jeremy Hunt, and he made a big thing about safety. And we all agree that until you can make it safe for people to say, do you know what, I've made a mistake and I'm really sorry, and the roof doesn't come in on them, and lawyers want to grab the money, and the patients get sidelined. Until we can get rid of all of that, your excellent report is a waste of time. You've got to start, why do things go wrong? And that's where we need to start. And I don't think your report does that.
That wasn't what I was asked to look at. So I was asked to look at regulation, responsibility and accountability. But I agree. I think we need to have a way in which we can have more openness. And at the moment, we're all aware of everything you just said, that there is nervousness on all sides. I can assure you there's work underway on all the things that you've referred to.
Let's just move on to the plan. Penny, there was a fair amount of scepticism in Blair's 2000 national plan, but it did actually achieve many, if not all, its ambitions. But crucially, it was lubricated by large investment. I mean, Roy's just mentioned it, but it was more than double during that period for what is planned between now and 28, 29. So 2.8% is actually below what the NHS has needed historically just to meet demand, and the service is in a kind of a worse state. Is this not the central problem that you face? And is there a magic bullet somewhere of technology or something or efficiencies that is going to deliver all this for you?
I would suggest that we look at the total budget. We look at the workforce numbers and we look at the activity. And if we look at what's happened over the last 5 years, the workforce numbers have gone up considerably more than activity. And even if we case mix adjust, which we have done and we can do, then it still doesn't match it.
That's because you've hired a lot of new people. A lot of them are very inexperienced people. And you've got to take into account your case mix, the population health. I think this is very sophisticated and it's very blunt to say we've got more people when we're not more productive without saying actually why.
So we have done a lot of analysis into the why. There's been very comprehensive analysis done into that, and it's been done at a regional level and it's been done at a national level. And I've already referred to case mix. So absolutely, case mix has become more complex, both in acute trusts and in primary care. But of course, we haven't seen such big increases in workforce numbers in primary care and community care. In fact, community care has gone down 5% in the last 10 years, when the acute sector has gone up by 36%. You're asking me a question, which is a perfectly valid question, as to how can we make all these changes without putting in massive amounts of additional money. And I'm trying to tell you some of the ways in which we can do it. So the first is there is a productivity opportunity. There is a productivity opportunity per se, and then I'll come on to technology, which adds to that. And then there is also, exactly as you just said, Roy, there's a piece around where is the money going, and is the money going into the most impactful areas of care? No. So if I do the first one, productivity, there's been lots of analysis that says a lot more money has gone in over the last 5 years in particular. The workforce numbers have gone up considerably. Yes, there are all sorts of factors. There's case mix, there's exactly as you say, Roy, newer people, higher levels of turnover, and so on. But we can see that there is also a gap, and that looks to be around operational management. So we need to go back to some of the things that were done. So it wasn't just the money in 2000, 2001, 2002, 2003. There was also a big focus on operational management. So things like the Modernisation Agency, there were programs that were looking at A&E improvement, they were looking at outpatient improvement. We need to go back to those. And certainly what I hear from chief exec colleagues and other colleagues is that is a significant area that we need to look at. We can see that also if we do look at different levels of performance across different providers. It is very different in different trusts, even though they might have similar levels of activity. So that there is a big thing that we need to look at around operational performance per se. And therefore, I mentioned earlier, we are going to be looking at our different improvement programs. We're going to be saying which of these are impactful and which of these do we need to change or even stop doing. So that's one bit. The second bit is that there is a bit of a magic wand has come along, which is called technology. And if we look at what's happening in technology in the rest of the world, but also what is happening in healthcare, it is suggesting considerable potential. And so it would make no sense to walk away from that. And the work that's being done, just to take one bit of technology on the ambient voice technology, it's staggering, absolutely staggering what's happening in primary care and what's happening in outpatients, which are the two main places where it's being used. So it really is having a big difference. It does feel a bit like magic, but that's having a big difference. There's then all the technology that already exists that other industries have adopted, and we have not. And that, for me, is really quite, upsetting and scandalous. The fact that we do have staff turn up, can't switch their laptops on. People talk about having to wait for an hour for their laptop or their computer to get going. It's just ridiculous. The fact that we don't have fully online booking available. I find that the most frustrating thing. The amount of time it takes me to book a simple thing like, a regular smear test or an over 50s health check or whatever, it's crazy. Why can't I just book it online? And the amount of staff time that takes to book those appointments is crazy. And then, of course, if you need to change it or you want to cancel it, you can't do it. So we have high levels of DNAs and so on.
The annoying thing is that we know what to do. But the basic stuff, your mutualization of data, we can do that now. We don't have to rewrite the software. But it's a 10-year plan, but we don't know what we're going to be doing in year 3, 7, and 9, because I don't know how we're going to implement it. or who is going to implement it. When you say, look at the basics of computer on wheels, that's right, isn't it? To get them to boot up in under 15 minutes. Well, the answer is you've got to buy some new one. And the answer is you haven't got enough bandwidth in the system so that everybody can log in at the same time. We know the answers, but the answer is bring money.
What I suggest you might want to ask me, that question is...
Okay, go on. I love this.
What does the delivery plan look like, Penny?
Well, there isn't one, Penny.
There is.
Well, if there is, publish it.
Yeah, we will when it's ready. Well, there's different levels of it. So at the moment, there's a high-level delivery plan, which is on about 5 sheets of A4, which is this, and this. But I literally, the reason I was 5 minutes late joining you is I've been sat here in my office with the team on neighbourhood healthcare, and we're starting to develop the next level of detail of that. I have asked, as indeed Alan Milburn and Wes Streeting have asked, to Jim and Sam, that we have a detailed delivery plan ready by the beginning of September, which seems fairly reasonable to us. So that will be 2 months after the plan came out, even recognising it's summer. And I think that is where we will start to lay out. I think it will be where we start to lay out, this is what will happen year by year. So there is already quite a lot of that in development, but we need to get even more detail on it. But it's things like, we need a much more detailed spec for neighbourhood healthcare, because, of course, that's the third bit of what I was going to say is we cannot continue with this model. And, you will quite rightly say, but we've been here in, 2008, and here's an extract from Aradazi's, High Quality Care for All 2008. Here's an extract from this. And I'm with you, in some ways, this has been one of the biggest disappointments for us as a country. And I'm being generous with the word disappointment, but over the last 15 years, we shifted right rather than shifted left. It's outrageous. That community budget going down by 5%. I mean, no other country has got that. Everybody else has. The response to the demographic changes, the response to more older people has been to invest in community primary care services.
Can you tell me, these hub things that we're going to do, are we going to have another sort of building fest?
The buildings are there. Hubs? The buildings are there.
You're talking about the GP surgeries?
A mixture of GP surgeries. We've got lots of GP surgeries with lots of spare capacity. Let's start to use those. And we've got lots and lots of other health centres. So I'm very happy. Where do you live, Roy?
Limehouse.
There you go. We can go on a walking tour of Limehouse and I'll show you where they are.
Okay.
Listen, conscious of time, there is one other kind of obstacle, I think, in the progress of all this, and that is how you take staff and unions and so on with you. So obviously we're seeing potential strike action at the moment. I would say that the NHS is filled with people with enormous goodwill, but actually collectively they can be warring tribes, they can be vested interests who recognise their own interests, which they think are the patient's interests, but aren't always actually the patient's interests. So my question is, how far is that a significant issue for you? And to what extent are you seeing the role of doctors and nurses and other professionals changing radically over the next 5 or 10 years?
You've both been chairs, chief execs, respectively, of large provider organisations. You've seen it up front. And we have, as indeed do other healthcare systems globally, by the way, we shouldn't kid ourselves necessarily different. We have a workforce that is probably more siloed than you would see in other industries. We have a workforce that is probably more professionalised with all the pros and cons of that than we would see in other industries. So, part of the challenge of this is how do we move forward when we want and we need people to be working much more as teams. All of that said, we've got some great examples of where people are already doing that. I can certainly point to several, and many people that would put their own hands up listening to this and say, hang on, we're already doing that. And actually, by the way, one of the things which I think is really interesting is if you look at primary care, so one of the big strategies as well from sort of 15 years ago was also about moving to more multidisciplinary teams. And we forget, actually, we've done that quite amazing. You look at the primary care workforce over the last 10 years, numbers of GPs have stayed largely flat, but the number of non-GP, it's gone up a bit, but the number of non-GPs has come right up. So we've now got pretty much equal non-GPs and GPs, or more positive language, we've got far more pharmacists, paramedics, physios, OTs, practice nurses, all working in primary care. So we forget that actually some things we have changed very, very significantly in the last 10 years. So that's one bit around the workforce. The other bit is what will the impact of the technology be? And that's going to be, so we do have the workforce plan, which we're now shifting gear to start working on that. And that will need to come out over the next few months or so. And that's going to need to get into the future workforce requirements and indeed ways of working, which is a critical bit in a lot more detail.
The future of work is the key to that. What work will people do?
Exactly.
Who will do it and how they will do it and where they will do it.
Exactly.
Will you get resistance, Penny, from vested interests within the service for what you're trying to do, or do you anticipate that this is all going to be seen as a win-win?
I think that was a rhetorical question. No organisation delivers a major change programme with everybody, every single person jumping up and down and clapping with joy. So, of course, it's always going to be hard.
And just final question from me anyway is this. Are you now genuinely optimistic about what's going to happen over the next 5 years? So that if we had a conversation, well, maybe at the end of your contract after 4 years, that you would be able to say, actually, we've done a step change here. There's something very different and quite radical has gone on, and it's producing all sorts of better results.
At the moment, we've got a Secretary of State who is very up for all of this, as you will all hear him talking about his 3 shifts and so on. I think we've got a fantastic top team of people now in place, and people I'm meeting out there in the system, chief execs, senior GPs, practice nurses, and fantastic group of people. It's very easy to get downbeat, but I have been to many other healthcare systems, and actually it's pretty good here. We've got very, very strong set of values in this country. We've got a very strong ethos around what are we here to do. We've got very strong past record and expertise around evidence-based healthcare. We shouldn't forget that, data, measuring things, thinking about what is effective in a way that many other countries haven't got that. So we've got an awful lot of things that are great. You can add to that, the genomic stuff is phenomenal. Absolutely phenomenal. I didn't fully realise that we are pretty leading edge on the genomic stuff globally. We're actually pretty leading edge, even though, Roy, I completely agree with you around some of the challenges on data. We're pretty leading edge on data. And actually, we're not doing bad on some of the new tech coming through. We've got an awful lot of digital startups in this country. We've got a lot of investment, private investment into those digital startups. And a lot of those private investors wanted to work in hand with the NHS as the biggest, by miles, healthcare organisation in the country to start to think through how do we test these things. If you add all of that together, I think we've got a better chance of delivering change and improvement now than we have had in the last 15 years. But is it going to be easy? No, of course it's not going to be easy. But am I optimistic? Yes. Though, of course, you might say you have to be optimistic to do this job.
I'm optimistic as well. I mean, I'm optimistic with the 10-year plan. I think there's nothing in it that I wouldn't want to do. I think it's a great idea. But the thing that, that everybody misses out, there's 1.4 million people working with us, and they all want change. Yeah. They all want better working conditions. They all want better kit. They all want better outcomes. You've got an army of the willing. Trouble is, they don't know where they're marching. They can't hear the tune. They can't stay in step, and they're all worried to death they're going to lose their job. Yeah. The biggest job, in my view, at the moment is the leadership piece. Leaders are visible, have a vision, and share it often. But thank you for talking to us.
Thanks very much, Penny. It was really good. Much appreciated.
It really was. Thank you.
Well, I thought that was extremely interesting analysis. Penny is extremely bright and she understands an awful lot about how the healthcare system works. I'm still nervous about how she overcomes the lack of funding, which has always been such a critical thing in driving these reforms. She did answer our point a bit about where is the delivery, and she's basically saying, well, it's not there yet, but we are going to produce a delivery plan which will provide a lot more detail, and detail that, for example, the King's Fund and some of the other think tanks have been saying, well, this is all very well, but where's the detail behind it? And she's saying they're going to be that. And you have to have leaders who are optimistic, and she's clearly optimistic. But I'm afraid I'm still nervous. I'm not saying that they won't achieve anything, and I'm not saying that for a moment, but I worry. We didn't touch on social care, but I'm worried about social care and the lack of funding for that and the lack of a solution for that at this point. But anyway, Roy, what was your thought?
Well, actually, I enjoyed meeting her, and she's got a sense of humour, knows her stuff, and you can have a debate with her. She's open to debate. But the thing that worried me most is we keep hearing the name Alan Milburn popping up. Almost everything that Alan Milburn did last time round was dumped by the Labour Party within 3 years. My personal opinion is I regard the man as an absolute menace.
I don't. So I disagree with you. I think his record actually is not that bad. What I would say, and I think it's an interesting point, is they did go under Blair and Milburn for a degree of competition or at least market testing of things on the grounds, and there was some evidence of it from other countries, that you could get providers to change their behaviour. My problem is an overstretched system, and it's more overstretched than ever now. I guess there may be some areas where you can do it, but I don't see it as a central issue.
I do. I think they're going to waste an awful lot of time, money, and effort trying to do it. And, it's okay. I mean, where I live, I've got, major internationally known teaching hospitals I can choose to go to. But if you live in Bassett Law, you've got one hospital.
Exactly.
And it's a total nonsense. And I just hope they don't waste energy on doing this at a time when I think energy in the NHS are much. The people who have to do this is probably at its lowest, and people are at their most worried. This is a rotten time. The NHS is a rotten employer, and this is a rotten time to be in the NHS. And it's the worst I've seen it. And they really need to buck up and try and get some motivation and some clarity back into the lives of ordinary working people.
I mean, I think there is a question of the clarity of the message from the top. And I think it's also fair to say to the current leadership that under successive secretaries of state and chief execs of NHS England, I'm not sure that many staff really understood what the NHS has been about, other than its big goal, for many years. So the question is now they've got to invent a narrative which is simple and easy to understand. They talk about the three areas, but even the three areas are quite difficult, because what does going digital mean to me in my daily life? And it's all very well saying, oh, yeah, we're now going to invest in community, not in hospitals. But of course, if you're in a hospital, the question is, what's your future and so forth? And turning one bit against another can also be problematic. And also, I raised the question, there are strikes on the horizon as well. Without going to the merits of them, that is going to be a rocky ride for this leadership, as it was for the last one, isn't it?
It's going to be much more difficult for Labour, because they came in and bought their way out of a strike the first time round. And everything that Wes Streeting criticised Steve Barclay for doing, he's doing. There's too much testosterone in all this. You don't start negotiations by slagging each other off. It's really stupid. There are structural problems in the way we employ junior doctors, and they should have been resolved last time. And this is the platform to resolve them this time. But standing up in the House of Commons, calling junior doctors greedy and parading a lot of old doctors saying what naughty boys and girls they are, that won't cut the ice with these. It's an entirely different paradigm, completely different generation, and they look at this entirely differently.
Well, I think there is an opportunity, actually, and I think you're absolutely right in that the reason why resident doctors are angry is probably not about 1 or 2% or whatever it is of their pay. It is, as you rightly pointed out, the generally in which they're treated.
The old boys, they wanted a career for life. These youngsters want a job and a life. And I don't blame them, because I would if I was them as well.
Roy, I think we should end there. Until next time, goodbye.
Yes, Neil. Goodbye, everybody. Thank you for listening.